Bismillahirrahmanirrahim. Assalamu alaikum viewers. As a part of continuous medical education program, we are going to discuss dyslipidemia and its management. We have among us the two eminent cardiologists of Pakistan to express their views based upon their more than 50-year experience in the field of cardiology. The panelists are Professor Shahryar Ahmed Sheikh. He is a diplomat American Board of Internal Medicine and Cardiovascular Disease. He is also a member of International Committee of American College of Cardiology. He is an elected president of World Heart Federation. Other is the Professor Solis Siddiq. He is a fellow of Royal College of Physicians, England. He is the head of Cardiology Department, Sheikh Zayed Hospital, Lahore. Honorable guests, welcome. So first of all, let me start by asking first question to Professor Shahryar Ahmed. What are the latest guidelines for the management of dyslipidemia?
I think the new guidelines now clearly state that if you have total cholesterol above 200, that has to be treated. Similarly, LDL above 100 has to be treated, and triglycerides above 200, that's also not very healthy, so that has to be treated. So in summary, cholesterol above 200, LDL 100, and triglycerides 200.
What is the significance of total cholesterol level in the development of atherosclerosis?
The role of cholesterol in the development of atherosclerosis has had its ups and downs, but in the past 15-20 years, I think now it's very, very clear that there is a direct and linear relationship between the total cholesterol, especially the LDL component of cholesterol, and the development of atherosclerosis. What it means is that with each milligram rise in the LDL and the total cholesterol, the incidence of atherosclerotic heart disease or atherosclerotic vascular disease anywhere in the body increases. This holds true even in the normal range, what to talk of the abnormal range.
Which is the most important fraction of cholesterol that contributes maximum to the progression of atherosclerosis?
I think like what Professor Solis was saying, that it is true that cholesterol, as we know, as the whole thing is bad. I mean, the higher the worse, but the most atherogenic part is now we recognize that the LDL fraction of the cholesterol is the one which is directly detrimental and relationship with the numbers to the progression and to developing the hardening of your arteries or atherosclerosis. And HDL, that we call as a good cholesterol, often the public thinks the bad cholesterol and the good cholesterol, that the higher your HDL, the better it is as a protective thing, and the LDL, the higher, is more damaging to the human health and to the arteries.
What should be the level of cholesterol and its subfractions, LDL, triglyceride, HDL, in a patient at high risk?
I think here we have to take in the new guidelines that if people, those who already have heart disease, they've had a heart attack or they have angina pectoris in the form of that, or people those who have equivalent, the people those who are diabetics, that we like to achieve in those people that the total cholesterol should be below 200 in those patients, and LDL level again in those patients should be under 100, and similarly triglycerides should be less than 200 in those patients. If you have two risk factors, in other words, that if you have two, like we know, smoking and hypertension and diabetics, those patients, if you have two risk factors, then again your LDL level should be less than 130. It should not go beyond that. Or if you have no risk factor or have one risk factor, maybe you have a liberty of going up to 160 in your LDL levels.
So our target should be the LDL cholesterol.
LDL cholesterol, that should be, as we talked about earlier, that's the one which is most damaging part, so that's very easy that we focus on one number very easily in these patients.
Who are the ideal candidates for statin therapy?
Those patients who have a level of cholesterol which is higher than what it should be in that patient population would be candidates. Our first measure is always lifestyle modifications, but if lifestyle modifications fail, then in patients with established atherosclerosis anywhere in the body, which would include coronary artery disease, cerebrovascular disease, peripheral arterial disease, or the presence of diabetes mellitus, which we now regard as an equivalent to ischemic heart disease, then the LDL cholesterol, if it remains over 100, patients need to be treated with a statin. In patients who do not have these but have 2 or more risk factors, then the level cutoff value is 130 for LDL cholesterol, and if the levels are higher than this, statin therapy should be started. For patients who have one or less than one risk factor and have tried lifestyle modification but have not achieved a total an LDL cholesterol level of 160, statin therapy should be instituted.
Sir, as we have learned that our target is the LDL cholesterol, then whether we should check total cholesterol, triglyceride and HDL in every patient or not?
Yes, because when you are checking, you have to check for all, because the method of checking is in such a way that you have to check for 3 out of the 4 fractions at least before you can calculate the 4th one. The other 2 which are not being mentioned here, the triglycerides and the HDL, are also important. HDL cholesterol in itself, if low, is a risk factor. And now the cutoff value in the latest guidelines is 40, not 35 as it was previously. So that is also being recommended as a risk factor, as an independent risk factor, even if the LDL is normal. If the HDL is low, that is an independent risk, therefore it must be measured separately. Same with the triglycerides, which were regarded previously, or rather ignored previously, now are being highlighted a little more, especially in women, that they have to be are an independent risk factor and therefore have to be measured. So unless you measure the whole lipid profile, you will not get all the required risk factor data.
How long statin therapy should be given?
I think again this is a similar situation we were caught with hypertension, that now we know that it is not only the numbers, that it's not that the statins do not only work that they'll bring down a certain level of cholesterol below a certain number and then you just fine. It's that we know that statins have lots of other beneficial effects in acute situations, in chronic situations. So I think we have to make the doctors and the public both aware, that which happens very often, that they will have a blood pressure, just your statins treatment given, they will have their cholesterol checked after a few days and they'll stop, that my cholesterol is fine, or the doctor will stop it. So the whole idea now is that once, particularly in established patients, statin therapy for that practical purpose, unless a side effect appears which is the physician decides, that it should not be stopped just because the cholesterol has come down or you have achieved your target level. So it is a lifelong treatment for practical purposes.
If the patient achieves the target goal of LDL and total cholesterol, then should statin therapy should be stopped or not?
Well, I think that question has already been answered by Professor Sheriar in the last answer that he gave. If you stop statins, 2 things happen. One, you lose the other effects of statins, the anti-atherogenic effects, which are independent of cholesterol. These are multiple effects affecting platelets and the endothelium and so on. Number 2, the lowered cholesterol was a direct result of the statin, and once you remove that, this cholesterol is bound to rise. So if you follow that patient up, you will soon realize that the cholesterol levels are going up again. So what we may do once we achieve target levels is to reduce the dose and repeat the tests after some time, see if that works and stabilizes the patient. If not, we may increase the dose again. It is infrequent for us to stop a statin totally, and that's why, as Dr. Sheriar said earlier, it most often is going to be lifelong therapy.
The statin should be started in an incremental doses, or when we have a target achieved with LDL cholesterol less than 100, then we should decrease the statin therapy, or we should stop the statin therapy?
We may attempt to decrease it and follow up. It's unlikely we will stop it for any length of time. We may stop it for a month or 2 months, but gradually I find that the patients will again come with a higher level.
Can statin therapy cause hypolipidemia if continued for a longer period of time, especially any neurological symptoms or any sexual problems?
I think in continuation to what we were discussing before we come to this important point, that these people, like it's just like we were discussing, it's just not the number, and even the earliest at the vascular level, the benefit starts at 6 months. It takes a long time before the statin will start doing what we really want them to do by lowering the numbers and keeping them depressed, those numbers, for a long period of time. Because people very often ask us, will their disease be reversed? Will their arteries open up? So now with the newest studies, as you know, for the first time we have evidence that we can cause a regression or a reversal in the process. Not only we can stop it, we can go backwards gradually. So I think what Professor Saurath was saying, I would like to re-emphasize, the medication should be taken in the adequate dosage for a long period of time. And I think coming back to your question, that does lower, if you lower to a lower level or too lower level, is that a problem? And I think still that's not been proven that, for example, if you lower your cholesterol to say 150 or 140 for even that matter, or LDL, now we in fact want LDL down, between 60 and 80, lower than 80 in people, those with established coronary disease, that it is unfortunately going to cause you any direct effect. You may reduce your medications in some people, but in most of the people this doesn't happen. It's very few that some people are very sensitive, and you will be surprised that their pressure, their numbers I've seen will go tremendously lower, like at 110, 120, 130. So you may either stop it for a little while and see what happens, or may reduce the dosage in those people.
So no neurological or any sexual problem has been noted?
I think not directly with just the numbers. Some people, particularly I would say, we discuss it, that the sexual difficulties can occur with statin therapy, but it can occur irrespective, lethargy with large dosage, those things can happen with, especially in higher dosage when we start them in some of those patients, but not a direct serious side effect as neurological problems or sexual difficulties. And even if you do, they get better if you just reduce them.
What is the role of statin therapy in the progression or stabilization of the atherosclerosis?
Professor Sheriar mentioned just now that with larger doses in the neostatins we are achieving some regression. Well, that's very encouraging, but actually the regression is very, very small so far. The main effect is stopping the progression of the disease, and in this too the main effect is plaque stabilization. What we mean by plaque stabilization is that the fibrous gap over the atherosclerotic plaque is less likely to rupture, because it is the acute rupture which causes coagulation at that particular local site and causes the acute blockage, which results in either a myocardial infarction or a stroke. So this is the main beneficial effect of statins.
When a family physician should prescribe statin therapy?
I think I'd like to maybe answer this in two different scenarios. One thing which we are noticing is that since a lot of people are aware of it, they will have their cholesterol checked, show the report, and a statin will be prescribed. That's not the idea, that anybody with 230 or 240 or 250 cholesterol, a young person, no risk factor, just maybe has his cholesterol checked, we discussed earlier, and just gets a statin, takes it for 10 days, goes back, checks again, and then normal, and then goes off. It's not like a 10-day course of an antibiotic, something that you give that. I think that practice has to be discouraged. So the whole idea is like when we approach a hypertensive patient, that when you're looking at a person with an abnormal lipid profile, you profile the whole person. Like what we discussed earlier with the guidelines. Does he have existing disease, coronary disease? Does he have other risk factors we talked about? And then decide to put him on a statin. So I think the general physician should not be scared of putting someone on statin therapy, but should go through what Professor was saying, that checking the whole profile preferably, and the setting is going to use it, statin therapy, and the dosage is going to use, and then monitor for the side effects, and it can be done. It's no much of a magic to the whole thing. that the liver profile, the muscle profile of the enzymes, that should be checked after 4 to 6 weeks of treatment. And then if the person is having no side effects, this can be managed very easily in most of the time by the family physician.
What are the side effects of statin therapy and what should be done in case of side effects?
Well, statins are generally very safe. The incidence of side effects is less than 1% in the literature. The main side effects are myalgias and impaired liver function tests, especially raised in transaminases. So if a person on a statin complains of myalgia, it is wise to check his CK levels and liver function tests. If the CK level is greater than 10, we have to stop. If it is less than 10, we may try to lower the dose and see if he adapts to the new medicine. If he doesn't, we may have to stop or change to another statin sometime. Mostly it's a class effect, but sometimes we can get away by changing the brand or to a different statin. In case of the transaminases, the recommendation is if it is more than thrice the normal value, we have to stop. But if it is less than that, we can continue with closer monitoring or more frequent checks of the transaminases.
Should statin therapy be prescribed to all patients suffering from heart disease or diabetes for life, regardless of their cholesterol level?
I think this is a very important and maybe partially controversial, but at the same time very important question. For practical purposes, for coronary artery disease patients, yes, maybe that level of cholesterol is just too high for him, whatever level it is. And there is now some thinking anyway that people, particularly in Southeast Asia, that maybe we should have a lower cholesterol level. But again, one should not forget the other group of people, those who have lower HDL and high triglycerides, the syndrome X and dysmetabolic situations and all that. But I think it is important because the statins do lots of other things which we're talking about, endothelial dysfunction to your platelets, stabilization of the plaque and all that. So the statins now have a definite role in almost everybody with established coronary artery disease. And similarly now, since we're talking about diabetes, that it is diabetes is like that those who have diabetes already has equivalent of a coronary artery disease, as if he has had a heart attack. So the diabetes is almost now a vascular disease. So I think what we would like to get our physicians' attention to is that in most of the people with diabetes and ischemic heart disease, established statins now become almost an integral part of the treatment.
What are the aspects that must be taken care for a patient on a statin therapy?
I think we mentioned this, we mentioned the side effects, and that is what you are looking for basically. So a clinical questioning of the patient. We repeat the liver function tests at 6 weeks and 6 months, and we should avoid adding another lipid lowering drug because that increases the potential for side effects tremendously. So if you need to add or give 2 lipid lowering drugs, the choice has to be very carefully made and the patient has to be very carefully followed.
What lifestyle modification is required by a patient on statin therapy, or continue statin therapy without lifestyle modification?
I think if I can give an example, it is similarly like managing diabetes without dietary precautions, or the lifestyle modification, that you keep on eating and keep on taking insulin or your sugar level pills. Similarly with hypertension, we talked about a similar situation. So I think with as relation to your higher cholesterols or high triglycerides or other fractions being not normal like your HDL, it's very important, particularly in our country, where the obesity, inactivity, the lifestyle and the dietary lifestyle that we have adopted in the last 2 decades, that should be very, very important. That if somebody is overweight, he's got to lose weight. I mean, the triglycerides are very easily respond to weight reduction, and just to a dietary modification, unlike the cholesterol, that's a little harder to bring it down. They won't go down more than 10-15% by the efforts that you put in. But in our situation in Pakistan, where we have low HDL and high triglycerides in lots of our patients associated with diabetes. So exercise at least 30 minutes a day, at least 5 days a week, and not only walking very, very slowly, but try and achieving, you know, 3 to 4 kilometers in that period of time. So a bit of a workout for healthy people, or most of the people can do that. So I think regular exercise, weight reduction, avoiding smoking, or cutting down other risk factors, that makes the basic, you know, number one situation before you start treating your these high people with high cholesterol or abnormal triglycerides. So this is extremely important that we spend an extra minute with our patients, and patients as far as the patients are concerned, also it's just not that they often have this, and while today I've eaten this, then maybe we should take an extra dose of statin that helps. It's not just one to like situation like that. So I think it's perpetual education and its effect which should go on to the patient as for diet, exercise, and similarly as the physicians.
Now, Dr. Salat, when we have learned so much about management of dyslipidemia, I would appreciate if you could summarize very briefly for our viewers everything what we have discussed today.
I would first like to start with thanking the organizers for arranging this continuing medical education program, and thereby causing dissemination of the latest knowledge on the subject. I'd like to thank Professor Shehryar. It's an honor to sit with him as a panelist, and to you for asking very relevant questions. We've learned that cholesterol plays a very important role in the genesis of atherosclerosis. Lowering cholesterol helps reduce the progression and may even regress the disease. In this particular case, the LDL is the culprit and causes the worst results, so the LDL has to be reduced. On the other hand, the HDL component of cholesterol should be increased because it helps reduce the incidence of atherosclerosis. The first defense is lifestyle modifications, which Professor Shehryar has mentioned in detail. However, they often fail to achieve the target levels, and we have to fall back to medication, and the medication of choice is a statin. We have a number of statins, and you can make your choice as you wish. It is important that once we start, the statin should be continued even if target levels are achieved, and it may perhaps be lowered, but it is infrequent that we will be able to stop it. So it's virtually a lifelong medication where the indications are there. The side effects are infrequent. Main is myalgias and impaired liver function tests. We have to be on the lookout for that, but as I said, they are rare, and usually we can continue with the drug for a long term. At present, statins are the mainstay of treatment for dyslipidemias and play a vital role in our fight against atherosclerosis.
Viewers, now that we have conducted this highly insightful and helpful session on the management of dyslipidemia, I am sure this will help you and will have a positive impact on your daily practice. Thank you very much.